Good afternoon, everyone. I'm Michelle Sharp, and you are participating in the Antibiotic Stewardship and Infection Prevention Collaborative webinar series. This is webinar 2 for the day, so we are glad that you could make it. Hopefully you've had some lunch, and we can keep you awake for the next couple of hours. I know we can. You can advance the slide. So just a few housekeeping things. During the webinar, be sure to use the chat feature to the right side of your screen. Make sure that you select to send your chat to all panelists. And so I'll have some directions there on the slide. Next slide, please. We'll also be using the polling feature. We ask for your participation, and anytime that you want to share throughout the next couple of hours, you will have opportunities at different points for discussion. So you can use that hand raise feature. The hand is located just to the right side of your screen, right below your name. And you can put your hand down when your question's been acknowledged so that we don't call on you again or unmute you again unintentionally. So again, whenever you want to chat, answer questions, ask questions, share, make sure that you've selected to send to all panelists so that we can see that and either reply to you or address it. Next slide. So if you're on this morning's webinar, you got all of this information already, so just bear with me. As part of this project, we have 21 participating PPS hospitals. Next. 16 participating critical access hospitals, all listed here. In the next slide, 21 participating nursing homes. So we are glad that all of you have chosen to participate, and then some. I know we have a lot of folks on the line who have came in after the fact and are eager to join in as well. So thank you for deciding to participate. Next slide. So our goal with this collaborative is to improve care transitions of our CDI patients, empower our pharmacists to improve stewardship capacity and implementation, and expand the implementation of evidence-based practice around MDROs. Next. So far, we've held our kickoff event, which was face-to-face in Little Rock on November 8th. We had 70 people in person, 40 on the live stream, which included 29 of our recruited hospitals, 14 nursing homes, and 3 non-recruited nursing homes. And also included our partners from the Department of Health, the Hospital Association, and the Arkansas Healthcare Association. We are doing this monthly webinar series that you're listening to now to provide education and coaching. These are scheduled for the second Thursday of each month, and registration information will come out as we get it put together. And then in July, we'll have our final face-to-face event, again in Little Rock. Next. So as the infection preventionists in your facilities, you should have received an email asking you to complete a survey. It included the paper copy of the survey for you to work on with your team members. And then after you completed that, we wanted you to log on using the link contained in your email and transfer that information from the paper survey into the online survey. Be sure that if you've not done this yet, that you get to it as soon as possible. And when you're answering those questions, think back to what you were doing prior to attending the kickoff event. So if you've made any changes since then or implemented anything new, we ask that you not include that in the survey. This was sent to one person in your facility, so we want one person to complete the survey from each facility so that we don't have multiple surveys from single organizations. In November, there was U.S. Antibiotic Awareness Week, and so we wanted to highlight a couple of the hospitals who did some work to raise awareness around antibiotic use. So Washington Regional did a lot of social media outreach to promote their Stewardship Center of Excellence, which was designated by the Infectious Disease Society. They also created this pledge poster to the right around stewardship. They had the providers sign that, and then they conducted TV and print interviews. So this was a really big poster on display for everyone to see. Next. And then St. Bernard's on the other side of the state. They did a lot of highlighting using radio interviews, newsletters, still a lot around social media. They promoted their cheat sheets with their providers, education in their emergency department around antibiograms and prescribing guidelines, and then they also utilized the stewardship video that TMF created and placed on their physician website. We want to let you know that our webpage is live, and you can go out to afmc.org/drugs and bugs, where you can find a toolkit, events, and information around our pharmacy scholarship. So we're going to look at take a look at what the webpage looks like. Next. So here's the home page. You have information about the work that's going on, and then over to the right you have a menu to choose from. Next. Under the Events tab, you'll find past events, including our kickoff from November, and then anything that's upcoming. So as we have new events listed or our registration available for our upcoming webinars, you'll find those there where you can click on the links and get registered for those. Then the Pharmacy Training Scholarship application, the link to that is also on our website. And the best bang for your buck, or the best deal you can get from the hospital side, is the Phase 3 1 through 3 full certification, which is $300 on your side. And then for the nursing homes, there's just the one option. So if you've not applied for the scholarship, please do. We've opened that scholarship application to all of our pharmacists in Arkansas. So please get out there, fill out that application, and then you'll receive more information from us. The toolkits and resources. So there's a page for hospitals, a page for nursing homes, and we have outpatient resource page as well. And underneath or on those pages, you'll find a section for antibiotic stewardship and a section for MDRO. And there will be multiple drop-down boxes, and each one of those are just active links. If you have anything that you want to share, or tools and resources that you may not find out on our website but you think they're worth sharing with everyone, please go ahead and send those to our email address, and we will see what we can do to get those posted. Next. Here's a list of the topics for our webinar series. Our next one is in January, where we'll cover tracking and reporting with stewardship, and then the big topic of data with infection prevention. Next. This is our team. So if you were at the kickoff event in November, you got to meet most of us. Next slide. And then here's our consultants. And so if we'll move into the next slide, I'm going to introduce Pam. And Pam is going to lead the discussion for the next couple of hours. Pam has had her certification in infection control since 1995. She's held leadership positions in the APIC chapter in Arkansas. She served the VA hospital as an IP for 27 years and was the director of IP at UAMS. She's currently the IP at the Arkansas State Hospital. So I'm going to hand this over to Pam. Welcome, Pam.
Thank you so much. Now, y'all, 2 hours sounds crazy. So I want you to know that we're going to have some slides. Then we're going to do some polling questions, have some more slides and discussion, more polling questions. So you'll be able to get up and walk around and run to the bathroom if you absolutely have to. But I hope to make this as interactive as possible, because what we're trying to do in this collaborative is ensure that all facilities in Arkansas have the most current content and guidelines, whatever best practices are in the field of infection prevention. And that's for both persons who are new to this role all the way to those who've been doing it for a while. So, I mean, basic information to advanced information. The webinars are going to be, as I said, interactive. We want you all to, I believe Michelle said, if you don't want to talk, you can chat. And you all text 90 to nothing, so I'm sure you'll be able to chat without any problems. The goal is that we take basic practice, the advanced practices, whatever barriers or pain points we have in our facility, and then work across organizations with our care transition, talking to each other, making sure everybody's on the same page in our patient care. All this collaboration is to move Arkansas forward. I do have to give you a tiny bit of history. In November of 1999, gosh, some of you might have been in grade school, I don't know, but a report was written called To Err is Human. And that report talked about healthcare medical errors. And it said that anywhere between 44,000 to 98,000 deaths occurred every year. When this article was first being presented, the question asked of healthcare providers was, do you know how many people in 1998 died from airplane crashes? And people would come up with some number, 10, 15. Well, the number was 122, and that was airplane crashes across the United States. And yet, up to 98,000 people died from being hurt in the place they go to get helped. So that led Congress to decide to establish the Agency for Healthcare Research and Quality and to set some national patient safety goals. So those are all pieces of where we've come in the cog, as you see here in our slide. In 2015, it was published that there had been about a 16% decrease from 1999 to 2015. That's maybe not as good as we had hoped it would be. And yet we're down to only 72,000 deaths in 2015. When you think about one of those 72,000 could have been someone in your family, or goodness gracious, one of us someday, we have work to do. The goal for 2020 is that the procedures that include lines or that have bundles, that there would be a 25 to a 50% reduction, depending on which line we're talking about, in your institution. Some of you have zero CLABSI for X number of days or zero CAUTI for X number of days. So keep that up. But the things that we still need to work on, we're looking for that 15 to 25% or 25 to 50% goal. And my question is, we've done zero on some things. How about could we do zero by 2020? So I guess the first question really is, who all's joined us today? You have 30 seconds to respond. I was supposed to tell y'all that, 30 seconds. And I could do the Jeopardy thing, but that would get really old. What I'm thinking while y'all are answering the question is, so we've got novice, we've got experienced people, but our purpose is all the same. People who become IPs have energy that you want to be able to educate your coworkers, family, Americans, so that we're all healthy and so that we can help not have to be so likely to be in the hospital and get exposed to practices and procedures where we might good gracious, get an infection. Again, over the next 6 months, what we're hoping to figure out is what are we missing? Why do we still have infections? So I am waiting to see, have any of you answered the question? We're still here, guys. We're looking at the IT people. You all must remember that I don't speak that language. One of them was telling me something a minute ago, and I asked if that was German or French because I don't know it. But it looks like, yeah, okay, here we come. I hope you guys can see these answers. 18 infection preventionists, 21 nurses, 19 didn't answer. Okay, you didn't answer, people. Wake up. Uh, lab person, pharmacy, other, and quality. So thank you all for joining in, and maybe others will join in as we go along. As we try to figure out how are we going to address all the things that we do, we decided to, and you saw that when Michelle showed you the calendar, we decided to just kind of break up our job duties. So today we're going to talk about surveillance and lab. We're not going to talk about all the other things that happen after surveillance, i.e., isolation, change in practices, etc. All that's later on. Today it's strictly surveillance and lab. So our next slide is, we're hung up, just a second, guys, some objectives. We always have to have objectives for our CEUs, but the literature is constantly being revised. There's always new ideas, new practices. People get things published that worked for their place. I know I've read journal articles many times and thought, wow, that's great, but I don't know if it will work at my spot. There are new critical rapid tests for helping us develop our new treatments, or there's antibiotics, and valuable lessons are being shared instantaneously. I know you all spend good time right away when something happens, instantaneously about it. So with all this information, all the places that people can tell what they're doing, we still have infections. Some of them are the patient's own flora. Everybody recognizes that. But the goal of modern medicine is to prevent even those types of infections whenever possible. So again, over this year, we're going to talk about some historical things that have led us to where we are, some great steps that have occurred that have brought us in better lights than we've been in the past. And we want to share amongst each other how to get past some of our plateaus. There's another polling question. Y'all, I'm sorry, I didn't see it. How would you describe your knowledge and experience with infection prevention? Ready? Are you a novice? I'm green and need to learn all I can. Intermediate? I've been working in infection prevention but still learning. Or expert? I'm a long timer and mentor. Go ahead and answer. All right. I think we're still getting some answers. 5 people said that they're novice. You know what? We all started there. Just know that the lady who taught me this job, after about the second week, I still wouldn't answer the phone. And she said, Pam, you now know more about infection control, that's what we called it then, than anybody else in this hospital. Of course, besides her and my boss. But once you start in this job, you get it and you read. And so you novice and you intermediate folks, thank you, bless you for doing what you're doing. Only one person answered as an expert. I don't know why the rest of you didn't answer, but that's okay. We're going to move on to the next question. What is your facility type? Acute care hospital? Critical access? Are you a nursing home or something else? We did finish the question, the objectives uh, slide, but that'll move after we do this. Okay, so who all's on the call? What is your facility type? I'm assuming you all know how to answer these. So back to my mentoring thing, I just want to tell you one more thing. Uh, as long as I've been doing this job, again, we used to be called infection control nurses, then it was infection control practitioners, and I think that was partly when we expanded and we got those brilliant lab people to help us out in this role. You can never read something too many times. Every time I read a new goal or, a new research article or um guidelines, every time I read them, I read something else. So we're all on the same page here, though we may have different experiences. Okay, back to the facility type. It looks like 13 people are from a PPS hospital, 11 from a critical access, 22 nursing home folks. Thank you, thank you. And then a few people still haven't answered, but that's okay. You might still be finishing your lunch. Don't forget to clean your hands. All right, one more polling question, then we'll move on to the surveillance definitions. This last question is, how well do you feel supported in your infection prevention efforts? A, I don't have access to much assistance or education. Or B, I have good support and access to education and assistance. That access, as I said, you can find so many things online. It's amazing. And sometimes things we read, quote, on the internet, end quote, may not be the most valid, but we in infection prevention have the CDC, CMS, OSHA, um, AFMC. We have so many resources that are absolutely wonderful access um, for us to be able to then turn around to our administration or to our staff that we are trying to teach. So, about 9 people said, well, I really don't have good access. The majority of you said that you do have good access and support to education and assistance, and that's really, really good. So we're hoping that having joined this collaborative, those of you who don't really feel that good access, you will know you can turn to us. You can tell us what you need, what you want, and we're going to do everything we can to accommodate what you're looking for. Okay, that's the last polling question for just right now. Let's get to our surveillance definitions. From the Dictionary of Epidemiology, surveillance is an ongoing collection, collation, and analysis of data, and the ongoing dissemination of information to those who need to know so that action can be taken. The APIC text has a very, very similar definition. It is a comprehensive method of measuring outcomes and related processes of care analyzing the data, and providing information to members of the healthcare team to assist in improving those outcomes. Gathering the data is only a piece of what we are to do. So, surveillance, excuse me, there is, oh, y'all. All right, this is my first webinar. So, that we just missed a question that was, what was your, let's see, do you feel like you have a good understanding of what infection surveillance is? Do you feel like you have a good understanding of what infection surveillance is? Yes, no, or I'm not sure. And don't cheat now because we just went over what the surveillance definition is. No, I'm kidding, y'all. Every one of you knows what surveillance is about, but sometimes it's hard to know the other pieces of the surveillance. The analysis of the data, collating the data, disseminating it, making sure that people on the healthcare team who need the information get the results of what your surveillance is, and working to improve those outcomes. Surveillance is a very essential component of our infection prevention program. Some days it seems like that's all you do is look up numbers or cultures, but it's extremely important. I think we're doing good, y'all, because this morning there seemed to be like a 2 or 3 minute delay from the answers to the polling questions. All right, so here we go. Most of you said yes, I know what surveillance is about. A few of you, and you may have just started. Don't worry about it. If you're not sure about it, we're hoping that after today's webinar, you'll feel a little bit better. Okay, so the surveillance of infection. In 1958, I'm going to give you a tiny bit of more history. In 1958, there were some outbreaks of Staphylococcus aureus in hospitals, and the American Hospital Association recommended that hospitals implement some kind of infection surveillance program. In the 60s, the early 60s, the CDC recommended that hospital-based programs incorporate surveillance activities. Y'all, by 1962, from Great Britain, Staphylococcus aureus had already began to become methicillin resistant. In 4 years, from 58 to 62, we were seeing our first MRSA in America. In 1976, the Joint Commission, back then they were called JCO, they first included infection surveillance prevention and control standards as a chapter in their hospital guidelines. Not everybody was surveyed by Joint Commission at that time. Then came along a study. It was called the Cynic study. And yeah, I remember that study. It was called the Study of Efficacy of Nosocomial Infection Control. And they looked at scientific evidence that hospitals who had strong surveillance programs, along with strong prevention and control programs, were able to improve patient outcomes and reduce what we called then nosocomial infections. Nosocomial was sort of dropped as the key word just a few years ago when we started doing so many outpatient things. As you know, there are all kinds of outpatient centers. So to be clear that if it's a healthcare-associated infection, not just something in a physical hospital building, nosocomial still implies something that happened because of healthcare. Anyway, After the publication of the Cynic Project in 1985, there have been many, many published articles, books, text to help discuss how to monitor the healthcare practices, processes, and prevent HAIs. But we still have them. So the challenges of our surveillance of infection include changing the healthcare system. A new slide. I've missed it. So let me just finish this real quick, y'all. The challenges dealing with our surveillance are the changing healthcare delivery systems, the emergence and reemergence of infectious diseases, all the mandatory reporting requirements, and again, after that first report in 1985, it was clear that if a facility had an IP program, I think infection prevention has always sort of been on the sideline in long-term care, but now it's going to be a highlight. And those of you in long-term care, I want you to blow out that chest and be proud. So what are the key concepts of a strong surveillance program? Again, Joint Commission, CMS, each state's Department of Health, any other regulatory system has principles outlined that we're supposed to observe and have principles that we are supposed to document to assure a successful program. IPs need only to search the web, read headlines. You can go to CDC, APIC, Becker comes online, journals from APIC, SHE, clinical infectious diseases. There are so many current recommended practice areas that we can find something else to try. One major issue, though, and we've already asked a polling question related to this, one major issue is we may find something we want to try in our facility and administration doesn't understand. Maybe they want to support it, but their first question is, how much is it going to cost? And do we have to do it? Yeah, sometimes we do. Once we get the buy-in, the funding, and we start something, the next part of the surveillance program, the IP program, is educating this direct care staff because they really still don't know for sure what we want, what we need, what we're looking for. I'm sure some of you walk onto an area and some person thinking they're being cute will look at you and say, hey, I'm not picking my nose, or I just picked my nose, but I washed my hands. I know you've heard that. Or people hold their hands up and say, I just cleaned my hands. And you want to say, and you're 6 years old or what? But, we smile and we're proud of them. Proud, so proud. Thank you for doing that. Okay, one more thing on the key concepts. If you look at bullet 3, the ability to identify risk factors for infection, here's one of the things that the ICAR, the Infection Control Assessment Review, has shown is that the monitoring the effectiveness of our interventions, that's really hard to do. Many of you, including me, when I filled out the ICAR, I wrote that, well, yes, I monitor, but how often? And if people know we're coming, they run in front of us. It's just like when surveyors in the building, people run in front of us and date their IV tubing or date their dressing changes, the dressings. So monitoring the effectiveness of interventions is something that we are going to need to kind of work on. And I'm hoping that any of you who have ideas about that, you shoot them to us throughout this coming year. Measures, though, that we have had that have been in place have been shown to be very effective. And I'm thinking of the surgical care improvement program, the skip measures, both bundles for CVL and urinary catheter prevention, the ventilator care, raise the head of the bed, the PPIs, all that stuff. So those things are now being done on a consistent basis, and we're seeing good results. But what? Yeah, there are still infections. So the components of a strong surveillance um, have patient safety and prevention of infection at the heart of it. They are the major aspects of the core prevention. Sorry, guys. Are we there? Okay. Um, so what we all want for our patients, our families, our coworkers, and ourselves, quite honestly, is for the strong surveillance program components to be put in place everywhere that we may be. Understanding the mandatory and public reporting requirements are there for a reason, and that is to constantly collect information to then publish to help reduce the occurrence of these infections by looking at what the risk factors are and what things we monitor that are not being done consistently. We already talked about the Cynic project. I want you to see the red sentence that even in 1985, we knew that there were improved patient outcomes by reducing HAIs, or again, nosocomial infections. Since 1985, we have seen additional facilities, long-term care, rehab facilities, ambulatory surgery clinics, dialysis units that are not in hospitals, home care, hospice, mental health, correctional facilities, all with some kind of surveillance for healthcare infections that have occurred. It dawned on me that since the Cynic project, that's 33 years ago. Again, some of you were not even born or just born when this project was published, and here we are, y'all. We are still having infections. So, we're still working on it. Factors that affect the surveillance programs, and these factors, y'all, were published both in a Shea journal and from the APIC text. Shorter hospital stays. Patients come in at 5 in the morning, have their gallbladder taken out, and by 10 a.m., they're in the car going home. But if they come back to our facility or a provider that reports to our facility, we may find some kind of postoperative infection. The population's getting older. They say that 60 is the new 40. I'll go with that one. So does that make 30 the new 20? I mean, do you stay 20 for 15 or 20 years? I don't know. Anyway, the population is living longer. They're healthier, but we have antimicrobial resistance. I think Dr. Crater probably mentioned that more than once this morning, and we all know that people take antimicrobials when they don't need them, they save them, and it's continuing to cause resistance. Increased use of invasive procedures and devices. Our patients that are living longer are more acutely ill. Our residents in nursing homes are sicker than they have been in years past. Currently, we even have healthcare worker shortages because, goodness, if you're an IT person, I think you're supposed to, you may make more money. Is that true, Mr. IT over there? He says he doesn't know. There's new and emerging and re-emerging infectious diseases, and that ever constant kind of in the back of your mind threat of bioterrorism. So the purposes of surveillance, to see what is our baseline endemic rate. What do we have in our facility? to look to detect and investigate clusters or outbreaks. And remember, a cluster can be two or three of something you don't normally have. An outbreak could be one of an unusual organism that you normally don't have. A quick little aside here. As you know, I'm currently working at the Arkansas State Hospital, which is a behavioral health facility. And last year, on one unit, 4 patients were diagnosed with influenza. And you need to understand those patients, once they are in the state hospital, until discharge, they don't leave there. So somebody brought in influenza and they wrote it up as an outbreak measure or as an outbreak. So outbreaks can occur and they don't have to be big, huge hepatitis A or measles or something that, Ebola, something that scares people. Okay, so again, the purpose of surveillance, I'm on about the third bullet, I guess, to look at the effectiveness of our prevention and control measures. Are what we're doing, are we doing it correctly, and is it helping? Looking at the adverse outcomes and look for other risk factors. We can provide information to our organization that can be used then to target performance improvement activities. It can also measure the efficacy of interventional or performance improvement efforts. With surveillance, we can observe practices such as our hand hygiene, maybe the sterilizer monitoring that may be done either from a large surgical service, sterile processing, or in a small outpatient ambulatory care surgery who has tabletop sterilizers. We can detect and report notifiable diseases to the health department with our surveillance. We identify organisms and diseases of importance to prevent their spread, not just know that we have them, but to prevent the spread. And then, of course, our surveillance ensures compliance with federal regulators such as OSHA, CMS, and although we've done some or all of these tasks, we're constantly working on them, there are still fragments of practices that are difficult to complete. How many times have you worked on these surveillance tasks in a day? You said to your coworker, your family, or another IP, well, I meant to do, you got sidetracked, or you got called to something else. The other side, the other end of the purposes of surveillance are, we're not done with the purpose of surveillance, y'all. Then we have our state regulations, state mandatory requirements. We have Joint Commission and CARF, which is the Commission on Accreditation of Rehab Facilities. You mention those two names to people, and especially infection prevention, and our heart kind of starts to patter because it seems that when these accrediting agencies arrive on site at our facilities, somehow something that we have absolutely no control over, they can twist and turn and write it up under something about infection prevention. Taking our surveillance information and then educating healthcare personnel to prove to them, and I don't know if prove is the right word, so if it's not a good word, y'all just flow with me, please. But sometimes our healthcare personnel don't understand, well, why do I have to do that? They look at us like we made something up. But if we take our surveillance, analyze it, and then can show them what we're finding in the literature, sometimes they say, well, okay. Our surveillance also helps monitor injuries, personnel injuries, mostly related to sharp safety things. Detecting a bioterrorist event or an emerging infectious disease, I think back several years ago when we had the Ebola, I guess that was 2013, 2014, something like that. That poor nurse in Dallas, Texas. If I had been that poor nurse interviewing that gentleman, I probably would have done exactly what she did. Who would have known to think about Ebola back then. And now that it's been this long and we haven't had Ebola, is that still on people's thought processes? That again is where, when we conduct facility risk assessments, we look at what kind of travel do people have so that when they come to our facility, that question is asked of them. Have you traveled to XYZ in the past 30 days? Or I think generally the question we ask is, have you traveled in the past 30 days? And then they'll tell us, well, yeah, I live here in Little Rock and I went to Monticello last weekend, you know. So we have to make sure they understand we meant out of the country. All right, so guys, anyway, so with that, all those things we have to do for surveillance, what do we find? Everyday bacteria that live in the environment, on our skin, in our bodies. Usually they're pretty harmonious with our lives. It's just that when they move to other areas or enter parts of our body that they're not accustomed to that germ, havoc. You do understand, because we mentioned it already, plain old Staph aureus is a bad germ, y'all. If it gets where it isn't supposed to be, it can cause all kinds of symptoms and it can destroy tissue. It is as bad as methicillin resistant Staphylococcus aureus. It's just that we can treat it with cheap penicillin. I remember in the late 80s when the ID physician who was teaching me my job said, Pam, I don't really know why we don't isolate for plain old Staph aureus. Now, you and I, as IPs, want to throw up to think about, oh my goodness, another organism to have to isolate people for. But his point was people poo poo SA, Staph aureus, when it is as bad as methicillin resistant. When we look at other types of organisms besides bacteria, most of our funguses can be wiped out or controlled with creams or topicals. Um, it's when they move into sterile body parts, like the blood, that they cause so much pain, and the treatment is so awful. Candidemias are found mostly in our immunocompromised patients, and what sometimes we don't know is just because somebody doesn't have cancer doesn't mean they're not immunocompromised. And sometimes we don't know when they first get into our facility, we being not you and me, the first line people, but the people giving them their first care, and they don't recognize that the patient's own flora could be what's causing these terrible infections. Again, the education of our employees and the patients to help prevent the development of these superbugs. You know, the last thing before the superbugs, when we talk about viruses, most of viral infections we can prevent with some kind of immunization, and I'm referring to Hep A, Hep B. Of course, Hep C doesn't have any oh, what am I saying, y'all? Vaccination, but we do have really good treatment. And there's not been a lot of resistance in the treatment medications. There have been some genotypes that don't work as well with certain, say, of the antiretrovirals for HIV, but for the most part, people with HIV, AIDS, live long and happy lives now. We treat AIDS like diabetes, just a long-term illness that is controlled with medication. So all of this we find out because of surveillance. And then we move on to the bigger, better, worser things. That's our multi-drug resistant organisms and our extended spectrum beta-lactamase producers, or our ESBLs. How do we get all this stuff? Well, the total or whole house surveillance has kind of gone out of favor, and that's mainly because if you do total house, you can't define in the population, well, who's sick and what do they have? So targeted surveillance is where facilities are moving, and that is what the CDC is encouraging us to do. Even if you have a small facility, you want to look at things that you can measure, trends that you can measure over time. You can compare groups. Did Unit A or um, Ward B have more of such and such than somebody else? More CLABSI, more CLAUDI. And if they did, were the organisms the same? So with targeted surveillance, you can actually hone down maybe even specific surgical site infection surveillance. So you want to look at all the gallbladder, um, uh, open cases of gallbladder or lap-assisted gallbladder cases, and you maybe only follow them for a quarter. And if after a quarter there's no infections, move on to some other targeted surveillance. So that's the value of you being able to measure trends over time and compare between groups. So um, the targeted surveillance focuses on those high risk, high volume procedures and potentially preventable adverse outcomes. So, again, ICUs, nurseries, our catheter devices, invasive procedures, not just surgery, but other invasive procedures, and then looking for our resistant organisms. One thing we've recognized over time with those bundles for the insertion bundles and care, it's not so much the insertion for CLABSI or CLAUDI or even ventilator-associated events. It's the maintenance. Do people get what they're supposed to be doing for the maintenance? That's another webinar, y'all. Sorry, I got sidetracked. We'll move on. We'll talk about that another time. So the next 2 or 3 slides, I just want to let you all see there's information in here for those of you who are experts, for those of you who are feeling pretty good, and for the novice. These are great resources. The website is listed there for you, and of course, those of you who are NHS reporting people, you know those definitions. They have the toolkits for us to use. The resources are just unlimited. I've said this already once. I repeat it. I've been doing this particular part of my career for over 30 years, and every time I open up and click another one of these headers, I learn something. So don't not look at these. Don't not. Poor grammar. I'm looking at Nicole. She's laughing. I apologize, y'all. But what I mean is don't ignore these just because you've been doing this job for a long time. You can learn something every day. Okay, the next slide talks about the CDC infection definitions for long-term care. Now, they're real similar, but as you know, long-term care has different requirements, different responsibilities, and the feelings of isolation and loneliness. Yes, patients in an acute care facility may feel lonely. Old studies, and I think even a couple of new studies say once you get put into isolation, people don't go in there unless they just absolutely have to, because putting on the gown makes you sweaty and you're in a hurry. And we're going to talk about that in more detail, but the definitions are just a tiny bit different. So if you're responsible for a long-term care facility as well as something in an acute care facility, you need to kind of review these. Also, the NHSN site has checklists, and they even have training protocols. They have some PowerPoint presentations, and you have to take them in order, and they're fantastic. So when you don't have anything else to do, sit down, go through them one at a time. Do one day and another a month from now, but do them, y'all, because they're really good. And those of you who are either going to certify for the first time in infection control or who are ready to recertify, some of the questions I betcha that APIC has used for our, or CIVIC has used for our certification exam may have come from these websites. The McGear, no R, not McGreer, but McGear. That is not a typographical error there. The McGear definitions were first published in 1991. They were not revised until October of 2012, and the revision started in 2008. I was fortunate because I was still at the VA then, and we have long term care affiliated with our acute care VA facilities across the country. And so the VA was doing a lot of monitoring, active surveillance, and publishing. So the authors that you see here, starting with Dr. Namali Stone, actually called on people from all across the country to help us, to help them review, revise, and rewrite these definitions. Now, the one big thing that I want to say about the definitions for long-term care, they added one section called Constitutional Criteria for Residents in Long-Term Care. And the constitutional criteria you have to have, that starts with a fever, leukocytosis, an acute change in the mental status from baseline. Some persons in long-term care are a little out there, but if they get even more out there, then that would be a baseline change, right, guys? And then an acute functional decline in their ADLs. Not just, I'm not getting up today, but I can't get up today. The fever thing went from 38 degrees centigrade, which is 100.4 Fahrenheit, down to greater than 37.8, which is 100 degrees. So it dropped just that 4/10. But in our elderly folks, many times they don't even mount a temperature response. Okay, so the next thing is the McGear Long-Term Care Checklist Tool. It was actually, you see the second website there, besides AFMC, is this was a tool that was produced by the Nebraska Department of Health and Human Services. At the end of this 1 year, who knows what the Arkansas Department of Health is going to be able to publish. You all are going to be part of that. I'm giving this plug because I want you to understand how important it is that we have you in this collaborative and how proud we are that you've agreed to be a part of this. Anyway, this document, this checklist, has had some things that were pulled from the 696-page CMS Conditions of Participation document. So, hey, guys, we don't have to read 696 pages. We can go right here. All right, I'm ready to stop talking for a minute. Do any of you have questions or comments that we can take a little break? Raise your hand, hit the chat button, raise your hand, or start typing away. And our wonderful IT people and Nicole and Jerry are going to help me out as we try to answer them. Actually, your question is, you're now in the prison system. You want to know if there's really any major differences in infection control in the prison system than in long-term care or acute care. Not really. The basics of infection control, as you know, is hand hygiene, respiratory etiquette, making sure your, I guess they're prisoners, are given their immunizations, and your employees also have their immunizations. So the surveillance in the prison, you could probably most easily follow the long-term care definitions because of the fact that even probably in your infirmary, you're not going to do a lot of invasive procedures. You may insert Foley catheter, you may insert IVs. That would all be basic nursing practice, infection prevention measures. Did that answer your question?
Yes, ma'am. That answers.
I think you said you guess.
Yes, ma'am. Yes, ma'am.
Okay, so there's really, and I hear you, there's really not anything specific that I can tell you, but I will write your name down, and I will see if I can find something, okay? Because now I'm curious. So I'll see if I can find something and get back to you. Thank you for the question. Well, okay. We'll just move on. Thank you, Tamika, for your question. All right. Now we're going to move into our multi-drug resistant organism surveillance. Um, Active surveillance is to basically a swab to rule out colonization or maybe infection. Passive is once you find out the patient's already been here for a while and now we get a culture result. Many facilities do perform the NARI swabs. In 1992, when we first were being introduced to vancomycin-resistant enterococcus, CDC said, "Oh, you're going to have to do rectal swabs on all patients who may have been exposed to VRE, such as the roommate of somebody with VRE." All right, now guys, let me just tell you, yep, I had to do that. And then we finally put our foot down, we in infection prevention, and said, "Are you serious?" Because it's embarrassing for us, and the patients usually say, "Get the H out of my room." It's been very interesting. So I don't think we see a lot of the active rectal swab stuff going on unless maybe the patient is not coherent. Maybe they're on a ventilator and not really there. What's more important is all the things we find from our surveillance and that employees understand how important hand hygiene is. How long it takes to find out whether somebody has an MDRO or any kind of infection matters in that whether or not we put somebody in contact precautions. That's where we still, y'all, don't have good understanding by our employees about what standard precautions are. People put on gloves to touch everything, but they don't put on their protective eyewear or gown when they're going to do something where they could be splashed or sprayed. And guess what? We still have infections. Some are MDRO and some are not. So how do you monitor your staff efficacies for practice? That's something that we've got to think about as we're moving on down past our other CDC guidelines. I believe it was February of this year, the latest clinical practice guidelines for Clostridium difficile infection in adults and children, the 2017 update. The update was actually released, I believe, in October of 2017, and in February of 2018, in Clinical Infectious Diseases, this journal article was published. We all need to read this and compare it with the CDC document, which has not been revised since 2006. It is on our Drugs and Bugs webpage, so you can go back to our Drugs and Bugs webpage and click on it. And it's very easy to read. The first 5 or 6 pages of the clinical practice guidelines are, this is the question, this is the answer. And like I said, 4 or 5 pages, but then the back of it is how they came up with those answers. Very, very well done, and I think you'll enjoy it. I mean, we enjoy that kind of stuff, y'all. Admit it. We like to read that. Okay, yeah, so here are the guidelines and the websites where you can click on these. You don't have to search a lot. In 2010, the guidelines for the treatment and practice guidelines for treatment of CDI, these 2017/18 guidelines, the definition and the manifestations of CDI weren't really changed from the 2010 document. But there are new therapeutic agents and molecular treatment. I'm talking about treatment, which we're not discussing on this webinar, and then different molecular diagnostic testing, and that we are going to talk about. There is a new test that I don't know enough about to talk about today. We'll talk about it next week, next webinar. But there's constant things coming out on how are we going to detect this infection as opposed to colonization. I do think it's very interesting, y'all, this 2017 publication to review the researchers looked through the literature from 2009 to 2016. They looked at 14,479 different citations. To add the pediatrics piece to it, they looked from 1977, yes, 1977 to 2016. And there were 3,572 citations that they used to come up with writing the new current practices related to pediatrics in this new guideline. So these are very well studied, published articles, and we only have to read them in theirs. It's 15 or 16 pages. So we thank the authors of those guidelines. All right, we're getting ready for our first multi-drug resistant organism polling questions. Right? Oh, we're skipping it? We're skipping it because I'm talking too slow or too much. Okay, guys? Sorry. Moving back on to the MDRO surveillance. We want to make sure there's diarrhea. If the diarrheas also could show evidence of a megacolon or severe ileus, maybe even the positive lab that would diagnose Clostridium difficile, or pseudomembranous colitis that could be found from endoscopy. The primary episode of symptoms is what we call the onset. And so you don't want to, our employees need to understand not to send stool that has been repeated or was repeated 8 weeks ago, because this is just going to be a repeat of the infection that we had already found. When we look at the definitions that NHSN wants us to use, of course, we have healthcare onset, and we have, which means it happened once the person was in the facility. That's greater than 3 days of admission. And then we have community onset, but healthcare facility associated. So if the person had been in our facility or some facility within the past 28 days, then that we have to attribute back to the facility they were in. If you are having trouble analyzing the data, and you have access to NHSN, you can use their computer program to enter the data. The computer will calculate the program for you to come up with a SIR, which is, as you know, the standardized infection ratio, and that takes the number of predicted, or the number of actual events divided by those predicted to get you your SIR. And you want your SIR to be 1 or under. MDROs, ESBL, good gracious, do we know our alphabet? Multi-drug refers to classes of drugs, and classes of drugs are penicillins, carbapenems, cephalosporins, quinolones, and so on. Those of you who listened to Dr. Crater this morning, you know that she talked about getting people to pay attention to how antibiotics are given, how they're taken, how they're abused, because we cannot continue to let organisms develop the resistance from all of these antibiotics that people take when maybe they don't really need them. What happens with the organisms is they develop the organism develops an enzyme that eats up the cell wall, and the drug cannot get in. So beta-lactam is the extended spectrum beta-lactam is the class of drugs we're talking about. And that's our penicillins. Beta-lactam, y'all, is actually the name in the molecular makeup of the penicillin, and it's a ring. If you vaguely go back to your chemistry and look at, the lines and the circles and the rings, so the organism develops an enzyme called beta-lactamase, and it eats up the ring so that the bacteria can't be killed. So extended spectrum means that the beta-lactam ring has been chewed up. Now, those of you med techs on there, I'm not saying med tech terminology, but that's the best way I can explain it. And I appreciate any comments you may have on helping me explain it better. The bottom line is the organism develops an enzyme and eats up the drug. Okay, resistance is identified after the organism is grown on a culture media, and geez, we may have already started the patient on some kind of antibiotic, so that's kind of how we know whether or not we have to change the drug. And somebody had asked, what is the difference between colonization and infection, or how do you know when somebody is MRSA colonized? Well, colonization occurs off and on throughout our entire life, off and on all different parts of our body, particularly Staphylococcus aureus, Staphylococcus epidermidis. When an infant is 24 hours old, Clostridium difficile can be found in the colon of the newborn infant. So colonization simply means a germ is present, but it's not causing any harm. Staph aureus is a transient organism. One day it could be in your nose or your mouth, and 2 weeks later it's not there. People who've had recurrent staph infections know they're getting ready to have another staph infection when they have a boil, or terminology is a furuncle, and that's when your clothes have rubbed, you've been sweaty, and your clothes have rubbed at your waistband or under your bra, your wherever something might rub on you can cause the staphylococcus that's colonized on your skin to abrade the tissue, and that staphylococcus then says, hoo-hoo, I love it, and moves on in, and that's what will cause boils. Young teenagers who pick their face when they have acne, you've told them, your mama probably told you, don't pick at your face. Many times that is staph epi that lives on the skin, and when people pick at their face and break open the skin, then the staph moves in, and that's what causes the pustules in acne. So colonization is germs are sitting there not causing harm. Once they invade tissue, then they cause an infection, and many times stress, poor nutrition, any kind of damage to our skin can cause the infection to occur. That's when we want to encourage people to remember about standard precautions. If you touch something, wash your hands. Okay, move in now to our laboratory. I wanted to put a picture here of Mueller-Hinton auger plate. The medtech people call it the MHA. That sounded good, didn't it, guys? Once the culture is collected off of whatever body site, it is swabbed onto this culture plate, and the culture plate will have discs on it. Well, once it grows, the germ is scooped up off the first culture plate and put on a culture plate with discs on it, and those discs are little pill-looking things, and they are actually the antibiotics that we want to test to see if we can treat that particular germ. So if you go Google and say culture plate with disc, and you'll get so many pictures that will show you if you've never been to the lab to see what the culture plate looks like. Um, I promise you at the next webinar, I will have it on as an extra added benefit of coming to the next webinar. But what happens is then that germ starts growing on the plate and it moves up toward the disc or the medication. And depending on how good that medication is at killing the germ will determine the circle around the drug, the disc, um, and that's area between the disc and how close the germ gets is called the minimum inhibitory concentration, or MIC. So if the drug can kill the germ doesn't get very close to that disc. If it can't kill it, that germ will go all over it. You won't even hardly be able to see the disc because the germ has grown over it. So I just wanted to mention that to you all when people ask, well, what was the MIC for such and such a germ? And many times they look at the resistance patterns, not just from this one culture of your patient, but throughout your facility, and come up with our antibiogram. Okay, so Clostridium difficile infection, it's also called C. diff or C. difficile. Officially, there are two classifications to C. diff, colonization or infection. In 1978, as the role of the IP was moving forward, insight was provided about preventive interventions that should be applied to target the care to prevent transmission of germs from people who had diarrhea. I think over the past probably 5 or 6 years, anytime somebody is admitted to a hospital, I don't know if we're doing this in long-term care yet, but somebody comes into your hospital and they're having diarrhea, and we define diarrhea as greater than 3 loose, non-formed stool in a 24-hour period. People with acute CDI, Clostridium difficile infection, have so many stools we can't even count them. So we put people in isolation until we know what kind of diarrhea they're having. In long-term care, many times we'll have people with gastrointestinal illnesses, norovirus, help me, I'm trying to think. I'm drawing a blank, guys, on one of our other most common in long-term care, but norovirus is a big one. So anytime somebody is admitted, until we get the culture back, we should go ahead and put them in isolation. One of the things about the isolation is putting patients in a private room or cohorting patients with the same illness. So you don't want to put somebody with Clostridium difficile infection actively having diarrhea in the same room with somebody with norovirus, because they could switch and carry those to each other. So I know most of the time we try to put diarrhea patients in their own room. That 2018 guideline that we're talking about, you all getting to read, because it's on our website, said that there were 500,000 cases a year of CDI, resulting in somewhere between 15,000 and 30,000 deaths. Many, many times this could have been avoided if people weren't given so many antibiotics. And y'all, that cost greater than $4.8 billion. What we could do to the national debt with that $4.8 billion. No, didn't mean to say that, didn't mean to sound political. I just cannot believe that what we're trying to do in healthcare is take care of people by giving them antibiotics, and we're causing we may be adding to the cause of their infections. All right, so the diagnosis, again, unexplained, new onset, greater than 3 unformed stools in 24 hours. They could or could not have fever or abdominal pain, plus a recent antibiotic or healthcare exposure. If you have somebody who's low risk, but they're having this diarrhea, fever, abdominal pain, go ahead and consider them as maybe CDI and send the stool, but do not test for cure, because somebody who stopped having diarrhea at 3 or 4 days after being on vancomycin PO, which is now the new recommended treatment. Again, we'll talk about that another day. When we talk about our care transitions coming from the nursing home to the hospital or hospital to the nursing home, you do not test for cure. What you say is, are they still having diarrhea? And if they're not, they're good to go. If they are, we got to keep looking because something ain't right. The other thing is, when the stool is to be collected, do not leave it at room temperature. What we have found in the laboratory results is that the toxin will decrease its strength if the stool warms up to room temperature, and our testing may show some false negatives. So as soon as the specimen is collected, get it to the lab, or if the lab's going to come pick it up, get it in the refrigerator. It needs to be stored 2 to 8 degrees centigrade, which is 35.6 to 46.4, so Fahrenheit. So your specimen refrigerator should be able to take care of it. I wanted to just quickly remind you all of some of the definitions that you're going to read about when you read the revised guidelines. And I'm not going to read this to you all, but I want to remind you that false positives and false negatives are important, because if we got one or the other, the treatment modality will change based on that lab result. So when we go, and I wanted to mention for those of you who are members of APIC, the Prevention Strategist, that publication they send out 4 times a year, the 2018 Spring Prevention Strategist had an excellent article, and the title of it is something like "Measures of Validity." And it's written that even Pam Higdon could understand it. So I encourage you, if you have that, it's still in the plastic wrapper, go ahead and open it up and read it, because it's really good. All right, now, our lab tests. The enzyme immunoassay can detect the toxin for both A and B. I don't think I mentioned this already, but not every Clostridium difficile species produces toxin. And if it doesn't produce toxin, it doesn't cause infection. So when we're doing the testing, we got to have the result of the toxin. And that's why this stuff is kind of complicated, and sometimes it's a 2-phase test. If you are in a facility or you are in a laboratory that does not have the NAAT test, which stands for Nucleic Acid Amplification Test. You know, that's again is those med tech people with all their fancy words. But girls and boys in med tech land, we are reading and trying to be able to at least explain to you that we know something. So the NAT is also called NAT, and it uses PCR technology. PCR, you may remember, stands for polymerase chain reaction. And what the NAT does is it identifies the small amounts of RNA or DNA in whatever the organism is. For example, in viral things, it can determine whether somebody has HIV, the PCR can, much faster than any other test we used to use. So for Clostridium difficile, 25% of the isolates that don't produce the toxin would never have a positive PCR or NAAT. The GDH is the protein that's produced by Clostridium difficile, and that stands for glutamate glutamate dehydrogenase. Let's call it GDH. That's much easier to say. That is a low-cost, rapid test. It has a high sensitivity and specificity, but you've, again, got to go on and do the toxin part of it. So if your facility has the latest and greatest PCR testing, that may be the main thing that is used. The multi-step algorithm, let's go ahead, go to the next slide. This we've already talked about. Go to the next slide. This is in the new recommendation guidelines, and it talks about if you have defined, pre-agreed how we're going to treat people with diarrhea. So before a clinician will order the test for CDI, have they been on laxatives? If yes, then stop. You don't order that test. But if and do they have new onset of diarrhea? If yes, then you order the test. And so what I wanted to include here for you guys is that both of all the tests are still good tests to do, whether your hospital has a laboratory or your hospital contracts with someone or your nursing home contracts with someone. So sometimes it takes more than 24 hours to get the results because of the 2 steps that have to be done. Patients with the positive toxin then are going to be more complicated, and they're more likely to lead to death if we don't get them treated quickly. Relying on the molecular test without the toxin is many times going to give overdiagnosis, resulting in overtreatment and increased healthcare costs. So let's just do some discussion right quick. What techniques do you use to ensure the use of specific criteria? Do you have hard stops? That would be your folks with electronic medical records. Do you have automation? Do you have a rejection policy, i.e., someone sends a stool specimen that has formed stool in it? Can the lab or the contract lab just throw it away, reject it because that doesn't meet the criteria of loose stool? What do your providers know? How do you educate them on when to test rules? I'm curious what other things you guys might do to prevent testing being performed when it shouldn't be. Raise your hand or type away. Because some people may need to know what's worked best for you if you have things other than these. I know that even the biggest acute care hospitals are still having the best practice alert, BPA, which when the provider, nurse practitioner, or doctor starts to order a CDI, a question will pop up and say, is this new onset diarrhea? Or the question may pop up and say, your patient has been on laxatives. Do you still want to order this test? That is, the best case scenario. But not every facility, critical access hospital or long-term care, has electronic medical record. So it's important that you, in your role, recognize the things that you need to try to do to let your folks stop to order. Okay, here's a question. What does a good rejection policy look like? And what would be the key points to include? Excellent. Does anybody have a policy they want to send in to us and we can post it on our website? The rejection policy is going to say the lab can throw it away if it has stool that is formed, that if the patient has been on, again, laxatives or has repeat diarrhea that they probably don't need to be tested again. Um, I don't, nobody else is mentioning that they have a policy, but let's we'll put this out and ask folks to send us what their lab does. Another question is, we also use best practice alerts, but find they are often bypassed. Oh my gracious, Patricia, or whoever wrote this. Um, it's everywhere, everywhere. The physician will see the question asked, your patient was on laxatives, do you still want to order this test? And the physician goes, I said it, didn't I? Or I typed it, didn't I? So I guess that's why we still have $3.8 billion being spent on treating CDI, because people get treated when maybe they didn't need to, or they get repeat treating. The best practice alert is only as good as the education and the understanding of our providers. Okay, thanks y'all and we will see if we can get some folks to send in writing from their labs what their rejection policies look like. So I already mentioned that if you let the stool sit too long, it's going to not give us a correct reading. So when you all are doing your surveillance, we need to ask staff, well, how long do you let the stool sit? Or how long does it sit before it's delivered to the lab? Because I think if they understood you need to take this to the lab right now, it won't sit there from 9 p.m. at night to 6 a.m. in the morning. And I don't know that everybody understands why it's that important. Once it gets down to the lab, the micro folks may not be there, but it will go into a refrigerator, and at least we know for sure it's going to be protected. So what processes do you have in place to prevent repeat testing or testing for cure? And how is this overcome during transitions of care? When you know the patient is no longer having diarrhea, but we are not going to retest for cure, how do you, either way, long-term care to the hospital, hospital to long-term care, how do you get that word across? And are we sure that people pass that word along? Do y'all know that I just now see people are typing? I'm so excited. Okay, so Michelle said, thank goodness for the transfer systems in some hospitals. It makes it much quicker to get samples to the lab. Right? I'd forgotten about that. So there are, in the transitions of care, we'll talk about this kind of off and on throughout the rest of the time, there are forms that are, I think, being tested that we're going to try to use in the state of Arkansas to help each other know what this patient's coming in with, especially when our patients are very sick and can't really explain what's been going on with them. Maybe their family or caretaker's not with them to when they're getting admitted and can say, yeah, Daddy's, this is his third bout of C. diff, and they've given him Flagyl and Vanc PO, and now they're talking about a fecal transplant. So this form that, like I said, we'll be sharing with you all in a later webinar is going to help with our transitions of care and our documentation to each other. Well, let's move on because we're about to run out of time. We've kind of talked about methicillin-resistant Staphylococcus aureus. We've talked about it came to America by the early 60s. I do want you to know that by the mid-90s, in teaching facilities, over 62% of persons admitted were admitted with MRSA. In the last 10 years, because of active surveillance and things that we're doing in this country, it has dropped. And when you all look at the data that is being reported to NHSN on our MRSA lab ID, at every one of your facilities, you are seeing less MRSA. We can do this, y'all. We can get to 0 infections. We just have to keep working and making our faces and our words be known. All right, we've talked about the difference between infection and colonization. When you get ready, if you are ever asked to teach someone how to collect a nary swab, make the patient blow their nose really good before you get that nary swab, because sometimes you can blow that little bit of staph right on out of there, and then we don't have to do isolation. I know you think I'm joking, but I'm not, because the staph can be that easily colonized. We get rid of it. We don't have to worry about it. Well, that's as long as people are washing their hands, right? Okay. The diagnosis of the infection. All right, wait, I got a question or a comment. Our infection prevention nurse tracks the testing and results to prevent repeat testing. Awesome idea. Awesome. And maybe in the prevention aspects, so that we don't repeat test, if we get to so few CDIs, everybody should be able to do that. Somebody else said we take lab directly to our local hospital, and it maybe takes 15 minutes. Beautiful. That should protect the specimen. We don't have electronic medical record, but we ask questions like the ones you just covered when the CNAs or the staff nurses come to us with concerns regarding a resident having C. diff. Beautiful. So, and I'm assuming that means you are able to document that for each shift, or the charge nurse or whoever's giving you report, so that we know this resident came in with this. We're putting signs and symptoms and the questions about tubing feedings and laxatives on the C. diff order. Great idea. We're hoping to gather some data from there so that we can present other changes to the physicians. Hallelujah, you're doing a great job. Our LIS does not allow order entry of C. diff testing for 7 days. There's another one. Great. So those are all best practice alerts and things that we can all learn from. So those of you who have not identified anything like that, please note the folks who have sent this to you. And I bet Nicole and Jerry can help me figure out how to get that to you all in like a little report or something, because those are great comments. Thank you so much. When we take the medical history for staff, an elevated temp, increased respirations, blood pressure changes, of course, those are the things that we talk about when we're looking at the constitutional symptoms. So you've got, if you don't have those first, and you got a culture with Staph aureus MRSA, then you know it's colonization. Wanted to just remind you, especially in long-term care, if you have a resident who needs dental care or has dental health issues, they are a little bit higher risk for MRSA infections leading to bacteremias, because our mouth carries harbors staph. I think I've already kind of mentioned to you all about the testing that the VA began in 2006. It was so intense. The VA spent quite a bit of money, but what happens in the VA is if something happens to a veteran and it gets in the newspaper, it never talks. The newspaper and the press don't talk about private industry, but they eat up the VA. So we, the VA, had to come up with some way to sort of redeem ourselves. And what happened is they implemented a program that each admission and each time that patient is transferred from one unit to the other and upon discharge, patients were given a Neri swab to determine whether or not they were community associated MRSA colonized, or did they develop MRSA while in the hospital? It got to the point where units would fuss at the unit bringing the patient. Well, I just did the Neri swab, and this guy was negative on admission now. He just came from your unit, and he's positive. What are you people not doing? Over time, the VA has really seen a dramatic, excuse me, I apologize, a dramatic decrease in MRSA colonization and infection. In the meantime, across the country, people have started doing Neri swabs on admission, and mainly in intensive care units. But it's a good thing to be able to track. There you go again, y'all. That's us and our surveillance. Other sites that can be cultured: the axilla, the groin, any place that skin is disrupted, um, are great places that Staphylococcus loves to go. Lastly, we're going to talk about our carbapenem resistance. Um, when we talk about Enterobacteriaceae, let me just remind you that that group of bacteria we also call the enterics, those things that we find in the colon, in the gut. And we have Klebsiella, Enterobacter, Serratia, Hafnia, Proteus, Morganella, Providencia, Citrobacter, Salmonella, Shigella, Yersinia. All of these can cause infections in different parts of our body, and they are so ubiquitous. They're in the soil, they're in animal and human intestinal tracts. So when someone is constantly taking antibiotics, then this genus of bacteria are able to produce toxins. They then can invade tissue and cause severe infection. So carbapenem resistance obviously means that the drugs in the carbapenem family are not able to treat these microorganisms. In the lab, there's only one test that's currently used to find the carbapenem-resistant Enterobacteriaceae, and it's called the modified Hodge test. Again, if you put modified Hodge test into Google, it will bring up a disc for you, a culture plate for you. And though I did not understand what I was reading, I want you to know that the picture is so pretty. It shows a little rainbow thing. So this test is a great way that our facilities are able to figure out whether or not we have the carbapenem resistance. Okay, so the carbapenem, the drugs, you see there on the slide, and we have other resistance has been found in Acinetobacter and Pseudomonas, the crap and the crabs. So we have to make sure that we explain that to patients so they don't think we're saying ugly words to them. But the CRE often carry genes that can transmit these high levels of resistance to other organisms. So that's why this is so important. That leads me to remind you all there is a toolkit on the CDC website, and it is listed on our Bugs and Drugs website. It's the CRE toolkit. Let's see, Facility Guidance for Control of Carbapenem-Resistant Enterobacteriaceae. I heard a rumor that CDC or somebody may start wanting us to report that in our list of reportable diseases. So get that off our website and read it over. It's very easy reading as well, and tells us how dangerous CRE can be. The diagnosis, I guess we've kind of talked about this. At readmission, anytime somebody has been diagnosed with a CRE, they automatically go into isolation. I think that's something that's being looked at because the literature is not real clear on whether we absolutely have to do that or not. And the CDC has enhanced precautions, contact precautions with enhanced precautions, which when you read them, I don't see the difference. But that's what CDC says, so that's what we try to do. And again, there's your website. We've talked about active surveillance testing. I'm running out of time. I do want to call attention to this journal article in Clinical Infectious Disease. It's really, really very good, a systemic review, and does a lot of studies. So if you have time and you want to read more, that's a very good one. Okay, there is modified Hodge test is good. So get this. Modified Hodge test is no longer recommended by the Clinical Lab Standards Institute. Thank you for telling me that. There are now 3 methods to confirm carbapenemase production: the CARBA-NP, the MCIM, or the molecular testing are the tests recommended now. So Susan Etheridge sent that to us. So Susan, is that in all laboratories, or for example, if my little hospital was to contract a small lab, would they still do modified Hodge, or would they have access to these other testing? So while I'm finishing my last slide, if you'll answer that for us, and thank you for the this lab test website. So that last couple of slides are just giving you more websites, things that we can do to try to help with our facility to facility transfer. And also you need to make sure your facility has some kind of flagging system to let everyone know this patient I'm admitting has previously been identified with a really horrible multi-drug resistant organism. So the next slide was kind of our closing slide, and the question is, what methods of notification do you have? What communication tools do you use? And what barriers or successes are you having with care transitions? So those are things I guess we will, if you want to just chat on there, type chat on there, we'll get all these responses and answers back to you all. I thank you for your time. Anybody have any questions that we can answer before I turn it back over to our awesome AFMC staff? Remember to send your chat to all participants. Raise your hand if you have a question that you want us to try to hear you. The MCIM is a very easy and cost-effective test to use. Okay, good. So maybe even small labs that are contracted will use it. I'm so excited you tell me that, because as soon as I get back to my little hospital, I'm going to call our lab and say, well, now I have been educated. Do you do this test? They'll think I know something, Susan. Any hands up? Does anybody see any hands up? Everybody needs to go to the bathroom and get a drink of water. All right, I'm signing out now, y'all. Thank you again so much. I've got my resources there for you, and turning this now back over to the AFMC people. Thank you for participating.
All right. Thank you, Pam. I'll just get Nicole to advance my slides here. Oh, there we go. Okay. Final comments, and if you were on the webinar this morning, you've heard this already, so go ahead and move the slide. If you've not had your ICAR visit, be sure and reach out to the health department for that. They're non-regulatory and confidential. It takes about 2 to 4 hours and requires a face-to-face commitment from you, the IP. The infectious disease physician will be there. They'll review your policies and protocols and review best practice with you, give you ideas and suggestions from what they've taken away after doing your assessment, and then recommendations on where you can do some improvements. Thank you, Erin. Yes, we've got a lot of really good feedback from the ICAR visits. Everyone that's had them done has loved them, so we highly recommend that you do that. The next slide, please. Here's who you can contact. Whoops, sorry, back one. Okay, either Margaret Holloway or Kelly Garner at the health department, and you can either email them or call them directly, or you can email their HAI program address there at adh.hai@arkansas.gov. Next slide. Or if you want to do a statewide antimicrobial stewardship visit, the SASE visits, these are also non-regulatory and confidential, 100% voluntary, do not take as long, 1 to 1.5 hours of your time. And again, they are face-to-face. A stewardship pharmacist fellow will lead and review. They'll highlight what you're doing well, any opportunities that they might find, and give you some recommendations, and they provide an outside voice of support for your program, which is awesome. Next slide, please. And then if you want to schedule one of these visits, you can contact Corey or Kelly directly, or again, that same web address, adh.hai@arkansas.gov. Next slide. So we just ask that you continue to tell us your stories and ask us questions. You can send anything and everything to drugsandbugs@afmc.org if you have questions of our experts, anything that you heard today that maybe didn't get answered or you want to learn more about, or if you're looking ahead at our next webinar and there's some stuff that you would like us to address, you can let us know on the front end, and we can do our best to make sure that we get that covered. That helps us in creating our education and making sure that we're talking about what we need to talk about. Next slide. So again, we'll be talking about tracking and reporting for stewardship, and then infection prevention data, and probably spend a little bit of time at the beginning of each of those webinars covering anything that's come out of these two webinars today that we think we can cover. Next slide. So again, we want you to talk to us, get out there on our webpage, check out the scholarship and the toolkit, share the scholarship information with your pharmacist. We've opened this up to all pharmacists in Arkansas, so you know, whether you're a nursing home and you have someone that you contract with, let them know. They can reach out to us. Just be sure and give them that web address there. And again, if you have any questions about the upcoming webinar topics or something you'd like us to cover, please let us know. Next slide. And the most important question of the day is how to claim your continuing education. So you need to complete the survey to obtain your CE. You must enter a valid email address, because this is how you will receive your certificate. So one email address per survey. You won't be able to list them. The survey closes December 20th, no exceptions, so anything after that we won't be able to approve. CE certificates will be mailed after the survey closes on December 20th. You can find the direct link in the chat, so you can click on that and it'll open it right up right now and you can get it finished, or you can access it by typing this link into your web browser, whatever works best for you. So with that, we are going to wrap up, and thank you guys for participating. There goes the slides. Thank you guys for participating. Again, here's the information on the ICAR visit, and we will see you in January, or you'll hear from us in January, and we hope to hear from you even sooner with anything that you want to share. So thank you for joining us. Don't forget to do your CEs, and we will see you later.